The broadcast is now starting. All attendees are in listen-only mode.
Hello, everybody. Looking forward to getting started here shortly. Um, as we kind of get going, we're going to start a couple of minutes after 3 p.m. Eastern. If somebody could shoot me a quick message just to know that you can see me moving my screen and that you can hear me, that would be helpful. We'll try to get started here in just a few minutes. Okay, everybody, we got lots of people joining here. We're going to get started at just a couple of minutes after 3 p.m. Eastern. And so just wanted you guys to know that I'm still here, and we'll give it a few extra minutes. It's kind of a larger, diverse crowd that's calling in from lots of different spots. So we'll give you a chance to get logged in. Okay, everyone. Good afternoon. Looking forward to talking with you today. Today's session is going to be covering mental health parity and addiction equity as a compliance update. We'll get into all of what that means as we sit here and post when everything was kind of passed. As you'll see here, a lot of this, what we'll talk about, is the Consolidated Appropriations Act that was of 2021, which was actually, to make it confusing, that's what they call it when they passed it in 2020, December 2020. So talking about the updates and the compliance items that are now new and required of plans as of that time, as of this passage and the updates that it has to mental health parity. Just a couple of items, kind of housekeeping notes. First of all, this session is being recorded. We're going to take live questions in the chat box and in the questions section. That when you logged into the platform, that right there, if you hear that, is a tornado warning. So I'm also dealing with a child that first day of school that we believe has strep throat. So other than that, there's nothing going on in Greenville, South Carolina today. So apologies. Hopefully, hopefully I won't get swept away here. So where was I? We're going to be recording this session. And send me in your questions or chat. I would encourage you to do that. That'll actually help me along the way. One of the things I like to do as much as possible is try to answer as many of those questions as I can as we go. So if it's helpful rather than saving them all for the end. We have a pretty decent sized group here, but hopefully we'll be able to get to all the questions. Also, too, you'll see that there was a handout that was loaded that you can download that's called NQTL analysis service, and that's going to be what we go over today. And of course, as I mentioned already before that big loud interruption, this is being recorded. Okay, so let's go ahead and dig on into what are we talking about. Just, this goes without saying, but this isn't tax advice. This isn't legal advice. This is general guidance. Any questions that you have about how to apply a law to your company, you need to talk with your own legal counsel or tax counsel. I'm not an attorney, and I don't play one on TV. Today's agenda, or now there's who watches TV, right? I don't do it on YouTube either. Today's agenda. I've seen so many of these things, guys, and there's lots of different ways to approach this. For anybody who knows me, knows that you've heard me maybe say before that I'm really not impressed with complexity. I really, really am impressed with simplicity. These are a bunch of little items, but they're broken up this way kind of sequentially to build your understanding of how this stuff works and what we're really talking about here. We're going to start by talking about, we're just going to review mental health parity and the Addiction Equity Act. We're going to use the acronym MEPA. What is MEPA? We'll be getting into all of that, but simply put, we're talking about treating mental health and substance use disorders the same way we treat medical and surgical. That's, at the end of the day, that's exactly what we're talking about. It's not real more complicated than that. Now, the application is a lot more complicated because of the way that we structure plans, but at its essence, that's what we're talking about. Then we're going to talk about when this is / was this due, when is, was this due. That's a hint. It's already supposed to have been done 6 months ago at this point at the recording of this session. Who does this apply to? Who's the party that's responsible for doing this? What is this comparative analysis that's required under this law? We'll talk about quantitative treatment limitations, which the acronym that you need to know is QTLs. And then we're going to talk about NQTLs, And then finally, we're going to talk about the risk. I have absolutely no idea how long this is going to go. A lot of that will probably depend upon your questions. Some of this is just, it's got to drip on you a little bit. It's actually not that complicated. So I guess you guys will tell me how good job I do of making it more simplistic to understand. So before we get started, just because there's people in here that I don't know, who are we? We are an organization that has done a lot of things over the past 5 to 6 years. In terms of compliance services, a lot of people know us through ACA reporting. A lot of people know us as Sky or Sky ACA reporting or Sky Insurance Technologies. That's how we started as an organization. We do lots of ACA reporting across the country for lots of people. We were one of the first people that were involved in that back in 2015. So we understand compliance-related items that require massive amounts of implementation at one time. I don't know many people that would have the experience of going from no clients to somewhere between 750 and 1,000 in 9 months. The biggest, I was a long time ago, years and years ago, 2011, I had an employee benefit agency that I owned a part of, sold to Gallagher. I'd done that. I was an employee benefit broker for 15 years, and that was long enough for one lifetime for me. But getting the phone to ring was the hard part. When it came to ACA reporting, we couldn't get the phone to stop ringing. It feels a little like that right now when we're talking about this NQTL analysis in the early stages. It's eerily similar to how things felt with ACA reporting. The second thing, we are self-insured plan services. Lots of people, you probably know us as self-insured reporting. Some people may understand about the app, the integrated member app. It's called PlanWell Health. We do reporting and analytics for self-insured plans. Okay, so why does all this matter? When we started looking at the NQTL and the things that I'm going to show you today, the MEPA compliance, really we kind of laughed. Like, it wasn't necessarily that we were looking to be in another business, because we have, a lot of you have heard me say, we have all we need, when it comes to just taking care of clients and trying to do a good job of what everything else we do. But who else in the world has got self-insured plan experience and compliance experience? And so it was one of these deals that it's almost like we didn't even have a choice but to do it. That's who we are. That's our level of expertise. And hopefully we'll be able to provide something that's beneficial and helpful to you here today. Okay, so the first thing we're going to do is we're going to talk about MEPA, Mental Health Parity and Addiction Equity Act. What is it? You guys can read, but I'm going to read it to you. It's a federal law requiring that health plans apply the same type financial and treatment limitations to mental health and substance use disorders as to medical and surgical. Right, what does that mean? Parity. We're trying to treat things equally. And so what the whole, everything in terms of what they're trying to accomplish in these new requirements that you're going to see that can be a little bit daunting. Some of that is, candidly, we've done that to ourselves as an industry. Things have just gotten pretty complex, and we have some really unique ways of managing claims. Well, some of those end up violating parity. And at the end of the day, anyone who's had an opportunity to experience the challenges of navigating through a health plan when it comes to like a mental health issue or substance use disorder versus medical surgical, it's a lot harder. That's really what we're talking about, is that mental health parity was all about creating parity and equity, and so that everything's treated the same. Now, what's the problem? That didn't really work. That was initially passed in 2008. And there's another slide, I think, in here later. But the bottom line is that when you read and do the type of research that I have done, I've had the opportunity to speak with attorneys in Washington. I've had opportunity to speak with people who have direct access to congressional staffers, multiple people. And the bottom line is, and as well as directly at the DOL, when the DOL did the audits looking for mental health parity, when they got into the weeds on plans, there were massive problems. Okay. And so it's not just the DOL, though. There are a ton of states that are either currently considering or recently have passed in this year or late last year laws and different requirements in and around this parity, What am I saying? We're not getting away from this as an industry. This is not going away. To give you an idea in terms of cost, I saw recently that mental health and substance use disorder cost by 2030, that's 9 years from right now at the time of this, they're expected to be higher in terms of cost than diabetes and cancer combined. That's a massive amount of money. And that's a massive amount of growth also too. Recently, earlier this year, there was Sun Life did I can't remember exactly what they call it, but it's their analysis of stop loss claims review for the prior year. And I remember watching it and specifically thinking, my gosh, the cancer drugs and how expensive those cancer drugs are. That doesn't matter. What they're saying is that the projections are that mental health and substance use disorders expenses are going to exceed diabetes and cancer combined in 9 years. So there's massive amounts of focus on this. It's not going away. And when they looked at the way that these plans actually operate, they found they are not in parity. It's not happening in reality, boots on the ground, when someone's actually using the plans. So tucked away in the Consolidated Appropriations Bill last year, in December of 2020, was lots of things, right? Transparency, broker commission disclosures, surprise billing, and those things have been big ticket items that everyone has been focused on. In with that, NEPA was amended, and it was amended very substantially in terms of some of the requirements that have to be done that we're going to cover. So that's what we're talking about. We're talking about parity, but not just old parity that's been around since 2008. The new and improved version. I don't have it in here, but also too, like for instance, New York has passed some regulations. Michigan has some things going on. California passed some regulations. Some of these require annual disclosures and reporting back to the state agencies. There's lots of moving parts and pieces going on, but that's overall what we're talking about. Mental health, parity, and addiction equity, and it's not going away. That's the main walk away points there. Okay, what is it? It does not require that you provide mental health and substance use disorders. However, I mean, let's be real here. Practically speaking, near every plan offers such benefits. Not providing it is going to be very problematic. But what it does say, we're going to look at these 6 different categories, different ways to classifications of claims. For instance, like office visits and outpatient in and out of network and inpatient in and out of network, all that. What it does say is that if you provide any MEPA benefits, any mental health and substance use disorder benefits in any one of those categories, even if it's emergency room, you have to offer it everywhere. So what am I saying? Practically speaking, we're not getting out of offering mental health and substance use disorder benefits. That's just how it is. But when you do offer it, so that's saying, you don't have to. Technically, you don't have to. But once you do, the mental health, and you'll see this acronym, MH/SUD. It's because all this stuff starts to kind of come together. So let these acronyms drip on you just a little bit. Mental health, substance use disorder, right? There has to be parity. There's 3 types of parity, 3 categories of parity. There's parity in regard to financial requirements, parity in regard to treatment limitations. Now, this is where we're going to spend most of our time talking about things that are called QTLs and NQTLs. Q refers to quantified. That means dollar amounts, meaning we can put a number on it. So we can put a number on it, and then non-quantitative, we can't put a number on it. Okay, so we'll get into this a good bit. And then aggregate and lifetime dollar limits. And so mental health parity, right? Mental health and substance use disorders have to be treated same way as medical and surgical, kind of step 1. Step 2, you don't have to, but you kind of got to have to. In reality, all 99.9% of plans, I would imagine, are offering it. And when you do offer it, it's got to look like these mental health and substance use disorder benefits have to look just like medical, and that we're having lots of different ways that we're measuring that. Clear as mud? All right, hopefully, let's move it on. All right, so when is this due? This is due 6 months ago, as of February 10th, 2021. I had to read that about a half a dozen times before that sunk in. I was like, February the 10th. And so I had opportunity to talk to some folks, off the record. The bottom line is when asked from a political standpoint to people higher up about this, you go, well, why February 10th? And their response was, you were supposed to do this in 2008. The DOL is taking, thus far from what I can see, more than relatively, a pretty aggressive stance towards implementation. Their goal is not to roast employers. That is not their goal. Their goal is compliance. And there's lots of reasons for that. We'll talk about where this came from a little bit later. But as part of this, plan sponsors have to perform a very detailed and ongoing. This is not a one and done thing. This is an ongoing thing. Now, it could potentially be easier, maybe not, depending upon what's going on inside of a plan. It could be easier moving forward, but this has to contain something called a comparative analysis. This is kind of a buzzword you're going to hear, this comparative analysis. And what that is a quote unquote robust discussion of all plans to ensure that there's parity. And so it's not enough. We'll talk about what the DOL will accept. It's not enough to go, hey, we're good, we're compliant. That won't work anymore. This is a detailed, robust discussion that was supposed to be done 6 months ago. Now, it's kind of interesting. We'll talk about it's starting to come to a head. All right, there's just between the TPAs, the things that TPAs are sending out to brokers, people are asking questions. I can tell you one thing, as a vendor, broker, a TPA, what have you, I remember being a broker, and something we always said internally was, surprised clients fire you. There's no sense in being surprised in this, especially if we're talking about something that clients are just finding out about that they were supposed to have done 6 months ago. Okay, so what is this? The DOL is not going to accept generalized statements about compliance. These are their exact words. We are not going to accept generalized statements. Yeah, we're compliant. That's one of the things that really frustrated the DOL in terms of their audits, is that employers would just dump a ton of information in their lap. None of it was really much of an explanation. It was just a lot of stuff. And they looked at it and said, this doesn't show parity. You're supposed to be looking at your plans and making sure that these things not only look like they are in parity on the surface, but also in operations. Say that again, because it shows up multiple times, and it's an important thing to get. We're talking not just about what the plan document says. We're talking about how your plan actually functions, even to the point of looking at claims that were denied, for instance, and comparing, well, what do denied claims look like for mental health and substance use versus medical and surgical? True parity in terms of the operations of the plans. They believe also, too, that, where did this come from? It came from very terrible DOL audit results. There's significant budget impacts that it makes sense as you start to think about it, with the amount that they think that is in cost for mental health and substance use disorders, especially as it continues to grow for the next 10 years. They believe this can have a huge positive impact on state budgets, because their theory is, and there's significant lobbying, there's significant organizations out there who are pretty smart about the way that they're approaching regulators to enhance their lobbying efforts for more compliance. They have pushed real hard that states can save money if people begin to get mental health and substance use disorder help when they need it. It's much less likely to become a Medicaid claim. And so that's their talk track, and based upon what we're seeing, that's working pretty well for them in their efforts. All right, so who does this apply to? It applies to fully insured and self-insured plans. Now, if you're fully insured, who's gonna do it? The plan, the carrier that you purchased it from. They are not responsible. Ultimately, you're responsible. So even if you're fully insured, you need to be asking some questions about, the carrier has everything, right? They're designing the entire plan. So they certainly have everything that's necessary to do the comparative analysis. But you're responsible to make sure that they actually do. And because you're going to have it. The reason you're going to have it is the Department of Labor can ask for it. Plan members can ask for it. I'm going to write myself a note, and I'm going to circle back because I want to talk about plan members here when we get further along. Plan members. Okay. So there's no exemptions for churches. There is a small employer exemption. Basically, we're talking about, if you're familiar with the ACA rules, we're essentially talking about applicable large employers. You have to apply the control group rules and everything, but pretty much what we're talking about is employers that are 50 plus. There's always, the self-compliance guide is like 39 dense pages with other references and what have you. So there's lots of little idiosyncrasies and like intricacies about the way that works. But small employers are not exempt if they purchased an insured product with essential health benefits, as was required under ACA. You start doing the math and you go, this pretty much applies to everybody. So in essence, though, in application, in practicality of the market, fully insured, your carrier is going to handle it, but you really need to make sure that they are. You need to make sure that you have something that you need to be able to provide to members when they ask for it. And I think that they're going to ask for it, and I'll explain why in a little bit. Self-insured, you've broken this thing out. You are the plan sponsor. This is your baby. And there's more and more resources to help you, but this is your responsibility. And you're going to probably be surprised for the employers on here, kind of the status of the market right now. So who's the responsible party? Self-insured plans, the employer. The plan is responsible. The plan is obviously going to have to rely on vendors, but they hold this responsibility. Of course, I already said fully insured employers. So in the very beginning, there's a lot of the plan sponsors would go, well, the TPA is doing this. Well, I know I've had some conversations with some of you guys that are actually on this session. That's not true. They are not doing this. And as we get into the analysis, I know exactly why they're not doing it. For one, it's not exactly the scope of what they do. They have a lot of the information. A lot of the work has to be done by gathering information from the TPA. But we have to analyze networks, people that are doing utilization management. There's a lot. There's lots of other moving. Put the PBM. Anyone essentially who's a vendor who is providing services that potentially could impact mental health and substance use disorder benefits in any fashion, in any fashion that would limit those so that they weren't equal or in parity with medical and surgical. We have to look at those people. So you can imagine as a TPA, they have outsourced networks, outsource utilization review, medical management, disease management, care management, all that. They're not putting all that stuff together. It's just not something that they want to do, and they certainly don't want the liability for it. But they know, obviously, at the same time, that they really need to give a solution. I'll circle back to that in terms of risk at the end. But there's some pretty bad risk to a TPA. They're in a pretty tough spot right now, but we'll talk about that. Who's responsible then? The employer, the plan. All right, so what is required? It is required, it's called a comparative analysis, and all vendors that are providing services have to be considered. That's essentially what I was just saying here. Okay. So what is the comparative analysis? We're going to look at a handful of things. First thing that a comparative analysis looks at is easy, annual and lifetime limits. Well, shouldn't be an issue. The only time I can imagine this would be an issue is on grandfathered plans, if those even exist anymore. So because of the Affordable Care Act restrictions on annual and lifetime limits, it's not an issue. For the nerdy among us, I've got some notes there that you can look at, but it's not that's a 2% issue or less. Okay, Annual and lifetime limits are very easy, but this has to be documented in this comparative analysis. This comparative analysis is a living, breathing document that has to be maintained. And also, by the way, is probably going to have to be reported on. The everything that I'm giving you right now is based upon the current guidance that we have. The current guidance, I'm actually going to show you guys this. This is because we have obviously a service that does this. You can go to help and you can go to DIY, do it yourself. This is the easy self-compliance tool. All right, easy, 39 pages. Not easy, not easy. That was joking about that. It's very not easy. Okay, so step one, annual and lifetime limits, pretty easy. Step two, quantitative treatment limitations. Quantitative, it means we can measure, we can put a number on it. Seems like it would be simple, but when you start getting into the regs, it's not exactly nearly as simple as you would think it is. First of all, what are we talking about? A plan cannot impose a financial requirement. It can't have a copay or a coinsurance or a deductible or any type of limitations of outpatient days or inpatient days or anything like that that is more restrictive on mental health and substance use disorders than it is for medical and surgical. Okay. Again, we're just saying they're saying you can have those things, but they can't be more restrictive. So here's an example. It's acceptable to impose a $20 copay for mental health visit and a $10 copay for primary care, as long as the copay for most of the medical surgical services covered by the plan is $20 or more. What does that mean? This is just an example to where you can have like a $20 copay for a mental health visit and a $10 copay for primary care visits. But there's math that has to be backed up, detailed QTL analysis and math to back all this up to determine whether or not you can do that. So, well, how do you do that? All right, so the rules are complicated, but the good news is that they're quantifiable. And so at the end of the day, though, what we're talking about is parity. And so what we do, and you can see, you'll easily be able to go, how in the world is self-insured reporting find themselves in the middle of this? Well, this is a lot of it. We have to take claims, and as we'll see here in a second, we actually have to take expected claims, which are going to be claims that haven't happened yet. And so what does that require? It requires actuarial assumptions. And the claims have to be broken out into 6 categories, 6 classifications and 1 subclassification. Inpatient, in and out of network. Outpatient, in and out of network. Emergency, and drugs. And so what are we saying? We're saying, just think about these copays, co-insurance, deductibles, all the rest of that. We have to analyze that on all 6 of these different categories. So let's just say, for instance, the inpatient in network. There may be lots of benefits that are inside that. You may have ambulance benefits. You may have some things that have a copay. Most things are probably subject to a deductible and coinsurance. All of the copays, the coinsurance, the deductibles, all of that has to be run through some math called the substantially all and the predominant test. And this kind of goes through what that is. So let me just give you an example. Let's say that, let's use inpatient in network, that we determine, first of all, we do this test called the substantially all test. So we would look at all of the claims that can happen in here, surgeries, inpatient visits, skilled nursing. We look at all of each one of those little things. And then we have to see, okay, are there copays associated with that? And then how much of the claims are going to be coming from skilled nursing? How much of them are going to be coming from surgeries? Are there And so we have to apply this substantially all, meaning if this financial requirement applies to at least 2/3 of the medical and surgical benefits. If it does, then we can have one for mental health also. It's kind of our step 1. I know your head has to be swimming, okay? There's really, unfortunately, not a lot easier way to explain it, but hopefully you're getting it. So we're going to have to look at inpatient. There's some assumptions and things we have to do so you can get that, okay, I can wrap my brain around it. We're going to have to do some math, but we can get there. Now, outpatient, that actually has to be broken, or can be broken into another subclassification where we look at office visits and non-office visits. Okay, I'm just going to stop right there. What are we trying to do? They're trying to make sure that we're not treating mental health and substance use disorders differently out of parity. They don't want that versus medical and surgical. And they want that in all of these categories. Now, you'll notice prescription drugs. We'll talk about that. You go, well, how are you going to do it in terms of prescription drugs? There's lots of ways. The way that the formulary is structured, who's making the decision about the formulary, are mental health and substance use disorder drugs basically just thrown into a specialty tier? What are the percentage of those drugs that find themselves in a specialty tier versus regular medical and surgical? A lot of stuff, right? And so that's just the PBM. So you start thinking, is the TPA going to do that? Nope, TPA ain't going to do that. Now, when we start getting into some of the, the way that the networks work and stuff like that, yeah, they can do a lot of this. They can certainly provide a lot of information to help. Quantitative, this is math. The rules are complicated, but we can get there. All right. And so the rule is going to say we have to treat mental health and substance use the same way and in parity that we treat medical and surgical. Okay, I think I've thoroughly beaten that horse to death. But it has to be based on expected cost. So we're not looking per se at claims information, but we are looking at claims information. Okay, well, that doesn't make sense. We're not looking at, we're having to use expected costs. So we're projecting forward. Those claims haven't happened yet. But as a plan or as a carrier, you have to use what they call adequate claims information, meaning it has to be specific to this group. So, we're going to be getting more and more guidance. The departments are going to be releasing more guidance by next summer. Seems like a long time. They've given us plenty. Like if you're getting the self-compliance tool, which is kind of the stuff that we do, NQTL analysis, if we're getting this stuff done, you're getting there. I mean, there's lots of stuff that are on the backside, like the way that New York is implementing this, and we've implemented some of their things that they require on a state-based level. But it's going to require that we're looking at expected cost. That's your walkaway point that you need to know, and then it has to be their claims. So you go, all right, well, how in the world does self-insured reporting find ourselves in that? Well, that's what we do, right? That's a large piece of what we do. Is we're getting claims information anyway. And so it helps us to be able to track this and to be able to substantiate it in a way that I don't know really much anybody else would be able to, or very few people would be able to. So like all the actuarial testing and stuff, we're including, that reporting level in our analysis. Quantitative. All right, now that wasn't the hard one. So non-quantitative treatment limitations, NQTLs. These are processes, strategies, and evidentiary standards. They're overall ways that we limit the benefits for mental health and substance use that aren't quantitative. You can't put a number on it. You could put a number and say, well, you can only get X number of days to visit with or an X number of visits per year to a psychiatrist or psychologist. You could do that. That's a hard number. These are things that are a lot softer than that. These are the areas really in which the regs obviously gets most of the focus. And this is where a lot of the work, the vast majority of the work ends up coming in. Okay. So what are NQTLs? I'm going to give you some examples. This isn't comprehensive, but these are just some. Medical management standards limiting or excluding benefits based upon medical necessity or medical appropriateness, or if a treatment is experimental or investigative. It's where you're looking at it from a pre-cert or concurrent review or retrospective review or any of these different types of reviews that you're looking at, medical management standards. Recently, there's a very well-known organization that provides these they were asked by one of our clients, well, you guys, what are y'all doing in terms of NQTL? And they were like, yeah, it's didn't really apply to us. It really does apply to them. They just haven't figured it out yet. And to everyone's defense, everyone has been busy. You guys have been, I know the people in here, what y'all do, y'all have been busy doing all this other stuff. And now you're about to go into 1-1s, which exactly isn't going to make it less busy. But I can tell you, do not sleep on this. This is not going away. And some people are going to find themselves in extremely interesting and challenging circumstances if they ignore it. Formulary design for prescription drugs, I kind of covered that one. Standards for provider admissions to participate in a network. Like what? Are you making it more difficult for mental health and substance use disorder providers, psychiatrists, psychologists? Are you making it harder on them to be in network, including looking at their reimbursement rates? I'll show you some of the from the compliance tool to where we're actually, part of our analysis is to look at the procedure codes. How much is the plan reimbursing for certain procedures versus what they like? For instance, what do you pay an ophthalmologist versus a psychiatrist? What's the dollar amount for the same procedures? Not only that, you have to go another step and go, okay, well, you may be paying the same amount, but what percentage of Medicare's reimbursement are you paying? Are you paying the ophthalmologist 180% of Medicare, but you're only paying your mental health and substance use disorders 120? That's not going to fly. And so this analysis is all about finding the issues that you have ahead of time and then fixing them. So what's the problem? The problem is that plans are dynamic. There's always stuff that's changing. The little idiosyncrasies about things like this, you can think reimbursement rates. That's not a one and done deal. Now, there's certainly, in my opinion, there's going to be more work in the first year, and certainly more work if you change TPAs and vendors and what have you. But there's always going to be a base level of work and updates that have to be done. Plan methods for how you go about determining what usual, customary, and reasonable charges are. Fail first policies. You might know it as step therapy. How is step therapy being applied? Is it applied more stringently to mental health and substance use than it is to medical and surgical? What about exclusions based on a failure to complete a course of treatment? That's another one. Anything in terms of network tier design or multiple networks, or who gets into PPO, who's out of network, direct contracts, all of that it's not necessarily saying that any of these things you can't do them. It's not necessarily saying that. It's saying you can't do it if you're treating medical and surgical better than you're treating mental health and substance use. Restrictions based upon geographic location. So in other words, you might have said, well, if you're going to use mental health and substance use, you have to use that in this area. Can't do that unless you're going to do the same thing on your medical and surgical. Facility type. There's lots of criteria. These are just some of them, y'all. There's a lot of them. Okay. What is the DOL looking for? They're looking at a plan. You have to demonstrate that this is a thing you need to learn. The processes, the strategies, and the evidentiary standards, the evidence on how you came up with these NQTLs works in the way that the plan is written and how the thing actually is paid, how it actually operates, that there's actual parity. That's what this whole thing is about, because you might have a plan document that says, yeah, we cover it all the same. We cover mental health the same, but when you start trying to get into a doctor, you can't find one. Or you try to get into a counselor, you can't find them. There's even language in there that you go, because immediately I said, well, yeah, good luck, taking a lot of these areas, good luck finding a counselor. There's even language that says, even if it means you have to increase your reimbursements for those providers and that you end up with more mental health and substance use disorder providers than you do medical and surgical, you still have to do it. It still has to, these evidentiary processes and standards, the evidence looks at claims history. What are you looking at? Who are making these decisions and the way that the plan operates? Another example would be, let's take it like, just say denied claims, or maybe it was pre-certification, what have you. On an ongoing basis, those claims need to be looked at. And it's one of the things that we're doing in our overall analysis is that once a year, we'll be getting the data and documenting from the TPA. Okay, what percentage of claims are you denying for mental health and substance use? So let's just say it's 30%. But then we get into medical and surgical and it's only 8%. That's not cool. The other thing is, this is the level of detail. What are the credentials of the people who are making those decisions? Is it a very low level person that can make those decisions for medical and surgical? And then you need a very, very high standards for mental health. You're starting to get into understanding why most people don't want to touch this with a 10-foot pole. It's complicated. It's very ACA reporting-esque. It's a lot like that. All right, so there's a couple of examples in here that we can just kind of walk through. Coverage for outpatient visits and inpatient hospital stays. If a plan or issuer classifies care in skilled nursing or rehab hospitals as inpatient, then the plan also has to treat residential treatments for mental health and substance use the same way. These you guys can read. I'm not going to read the other ones to you because I think there's a couple more over here. I'm not going to read this one. What are we saying? It has to be treated in parity with the way that the plan actually operates, not just the way that the plan document looks. Penalty for failure to obtain prior approval for treatment. And so that's pretty straightforward, right? There's some details, but if a plan requires prior approval for a course of treatment to be quote unquote medically necessary, then it's going to have to do that equally between everything. Okay, so you got that in the slides. I want to give you guys this is the example inside the comparative analysis tool. I'll actually even go. It's here at the very end. There's a section out of it. These are provider reimbursement warning signs. So they have certain warning signs that we've kind of built into our process that we're doing this with. And one of them you can see here, look at the cardiologist and the CPT codes and how much is that versus psychiatrists and psychologists for these CPT codes, these procedure codes. And so we have to look at that. We have to compare it to Medicare. We also have to compare it to one another. So you start going, all right, well, that's the network. The TPA may do that. The bottom line is that it's just a lot of work. And, on some of the things, honestly, that like if the TPA is reviewing it, and, it's almost, I don't know, I guess different TPAs that have different perspectives on it. I will tell you thus far, I have not seen any TPA. We're integrated at self-insured reporting. I think we work with 100 different TPAs and PBMs. A lot of the PBMs we've talked to did not even know what was a thing. They had to Google what NQTL was. Some TPAs the same way. These are not bad people and these are not dumb people. These are people that have a lot of stuff going on right now. That CAA put a lot of things into work. I'm telling you guys all this simply because even though we're 6 months late, you're still on the front end of the curve of understanding kind of where we are. As I dug into it, I just kept going, oh my goodness, I can't believe how far behind we just are. This is what the DOL says. They issued out some do's and don'ts because they're trying to make this thing simple. Do, get a detailed and thorough analysis, follow the content requirements by the guidance. This is the guidance. There was one thing, I think they had said, let's see if I can find it. I think it was simple. It was, simple compliance. Make showing compliance simple. I thought that was, someone's laughing about that one. This is not simple, y'all. The data processes, strategies, how did you come up with your NQTLs? What's the reason that you did it? Because it's not necessarily saying you can't do it. Now, one of the things actually we hope to do through self-insured reporting and some of the analytics and stuff is actually to find areas over time. This is not going to be an immediate thing, but we're going to, this is going to be a hit. It's pretty obvious to me doing what we do that it's going to be a hit to expenses, to cost of employers. We're hopeful to actually be able to look at the data and kind of auto search to figure out maybe opportunities for more NQTLs that a group hasn't done yet. Stay tuned. That's going to take a while though. But that you want to do those, don't be vague. Don't provide a cursory, just general compliance statements. Things not going away, y'all. Offer documents to review instead of detailed reporting. That's another thing that in the audits is that they just dumped them in everyone's lap. I talked to another attorney, and he said that he's in the midst of a DOL audit with a client right now, and they're starting. It has nothing to do with NQTL analysis, but they're asking for it. He said this is becoming standard item that they ask for. It's no different than they ask for 5500s when they go in to do an audit. Providing explanations without comparisons, and this is their language. Assume the carrier or TPA is compliant. This is a bad idea. I'll leave it there. Again, these are not bad people. These are people that have a lot of moving parts and pieces. And these are, in fact, some of the smartest dang people out there. But I mean, my gosh, we have all we can eat, at the end of last year in terms of compliance and the new stuff that's coming. But you can't sleep on this one. There might be other things to sleep on, but I'm just telling you directly from the mouths of congressional staffers, this is a top enforcement priority. So what are the risks? TPAs, as I've looked at this thing, there's PBMs, more so probably the TPAs or people that do medical management. There's something called global correction enforcement. If you don't believe me, you can actually come to NQTL analysis, and then you can come down here like in this TPA and vendor risk and click on learn more about MEPA enforcement here. What this talks about is about something they call global correction enforcement. What does that mean? If the Employee Benefit Security Administration finds that one of your clients is not compliant, they'll audit all of them. That sounds like a great way to go out of business. So they go in, they do an audit, they find an issue with one of the clients, and they go, hey, well, we can clean up a whole bunch of compliance here in short order. Let's just go to this TPA or this medical management vendor, because if they're doing this across the board, then then we can get a whole bunch of this stuff cleaned up at one time. This is another one, y'all, that I'm seeing out there. TPAs that have written plan documents on behalf of the employers that are not compliant. Now think about this. The vast majority of plan documents are not even close to good. I mean, just simply put, they're kind of boilerplate. They haven't been looked at by an attorney. Now I'm tight. I like to run everything in the world lean that I can. There's some things that you have to spend a little bit of money on though. If you're self-insured, plan sponsor, having a plan document, if you go to court, that's what we're talking about right there. It's really important. But TPAs who've given they've given the plan documents to the employer has adopted it. And then now, since February, they're out of compliance, but the TPA hasn't told them that they're out of compliance. That is no bueno. That is not going to end well for the TPAs that have done that. That's pretty self-explanatory to me. It doesn't take a lot of logic to figure out that that's a bad idea. All right, so what are the risks to plan sponsors? By far, in my opinion, and I've been engrossed in this thing for, up to my eyeballs with it night and day for quite a while. Member lawsuits by far, both individual and class action. Sound as a business, someone who owns businesses, that sounds like something that's terrible. So what do I mean? Let's say, for instance, you had some type of treatment limitation of any type that kept someone from getting care, kept them from getting into a mental health institution, or kept them from getting a certain prescription. And God forbid something goes wrong. The person commits suicide. The person has an adverse health outcome. Who knows what that could even be? They can sue your company. They can even put together class action, with the other members for benefits. It's not necessary to go out of business over. And that just sounds like now, what is the likelihood of that? Unfortunately, I think higher than maybe other folks might think, because you go, okay, well, who is going to ask for this analysis? It's a great question. I went back, circling back to my notes. First of all, obviously the DOL or HHS, like if you're a governmental entity, HHS is going to be the one that audits you, not the DOL. I think I got that right. If not, somebody I'm sure here will correct me. But they can ask for it, obviously, and the DOL already is asking for it when they do audits. But your plan members can also ask for it. So when you read the commentary and all the comments from people that are smarter about this stuff than me, they go, what are they going to do with it? They're going to give it to their provider, right? They don't know what to do with it. But has anyone ever had a self-insured plan where the provider was paying the COBRA premiums? Hello? Yes. Now, why would providers do that? To get paid more money. They feel like they've been slighted for a very long time. So they would absolutely say, hey, what you need to do is ask your employer for this analysis, and we can make sure that your mental health and substance use disorder benefits are adequate, and that that they're paying everything they should. So the member just goes, yeah, sure, I'll ask for it, and then they'll send it right back to the provider. When you go look at the lobbying organizations, like you're down into the weeds about how that stuff is happening, it's going to be happening. All right. So they're going to be asking for this stuff. And again, that's not necessarily meaning that you have a problem. It's just some work that you got to do, and make sure that everything is legit. You can also have IRS penalties, which, aren't, they're consequential, $110 per member per day. That is not a huge focus of theirs right now. Now, as they come out with reporting, it may, it's kind of like ACA reporting. I'm not saying they have good faith effort, right? But if you're heading down the road, with ACA, you could get away for years with, kind of trying to be compliant, and all the rest. You can't now. You cannot today. But, for years you were able to get away, with penalties. I anticipate, and a lot of the commentary believes from legal experts believes it's going to be the same kind of thing. Again, their goal is compliance. Their goal isn't to hammer people. Which kind of leads me back to why member lawsuits become such an issue. But there's ways that, if they're in a DOL audit and you have their scrutiny, obviously if they're there looking at everything, they're going to ask for this, they're going to look for it. If you're in any type of audit, not tons of people get audited, which is why there's two things expected to happen later this year. One is that it's anticipated that they may release a huge batch of just letters to employers, I don't know how many, but a large batch is the commentary that I've seen, and saying, just send us in your comparative analysis. We just want to take a look. Now, they may or may not review that, but you can imagine if your client gets that letter, that's going to be no bueno if you haven't talked to them about it. Like, what is this? So, we anticipate that. And then with the reporting, there is some state-based stuff already and some state-based penalties. More to come on that. But overall, things are kind of gelling around this. Sort of looks like the way that New York is doing it, which is dang close to the way that our showing compliance simple guide, or 39 page simple guide. So how do you get this thing done? 4 options. This is straight off of our website, which is why it's a little funky. Help here. You can get your TPA to do it. Most people are not doing this. You can get your broker to do it. There certainly will be some brokers that have the technical ability to do this, but it's pretty complicated. And who's going to want to do that? I'm not sure. You can do it yourself. You can just simply click right here, get the non-compliance. Is that a Freudian slip? It's tough, y'all, right? I think you got the point. It's hard for me even at this point still. Or you can hire somebody. We're coming out in terms of pricing. You can reach out to us if you're interested in terms of that. Haven't seen anybody less expensive yet. We same kind of deal with ACA reporting. When we first started ACA reporting, our pricing was like, it was, you can see here with different levels of service and such. We'd start out this and people be 5 times more expensive than we were. And we were like, we think that this is fair. And so, we can give you a quote, but pretty straightforward. A lot of it's going to have to depend with you for standard plans. I can tell you that our pricing as of right now is $39.99. On renewal, I'm still not 100% sure what that's going to be. Probably best to count on it staying that way, although I think it would be a little bit less expensive ongoing. But some of that's going to depend upon what we end up getting in terms of reporting and what have you. For certain vendors, obviously, that have larger blocks of business where we're rolling out, there'll be a little bit of discount off of that. But that's kind of what you're looking at. Most folks in the marketplace are a good bit more than that we're seeing. Okay, I've looked through, and I think I've answered the questions, but I want to read here. One is just a comment I'll read. I tend to agree with you. The Department of Labor recently received an enforcement boost in the budget proposal of $2 billion and increased staff by 2,300 people. As the new administration takes shape, employers can expect new rulemaking and an uptick in enforcement activities. That's coming from a guy who knows a lot about a lot. So let me kind of look through here. Answered the one question on how you find the compliance guide. I got that one to you. Yes, this is recorded. You can just ping me, and I can get it to you. In terms of the cost, in terms of the cost, where we're at right now is that it's not on the website. I'm a little reluctant. It's not going to be higher than this, but it may end up coming down minimally, but not likely. $3,999 a year. But stay tuned on year 2, because we might only be doing that figure if someone moves. Because if you don't move TPAs, you don't change networks, we still got a lot we have to do. We have to look at all the claims. There's ongoing training. Because you need to have a mental health parity compliance officer. According to these New York regs that we think will be the model legislation, that person needs to have some direct contact to higher, not like this huge long chain of command. That person needs to be able to get the word to the important people in your organization about parity. So there's some things like that. And of course, there's lots of ever-changing organizations. It may come down a little bit from that. And for a lot of times we'll partner with TPAs and you're a broker to where we're mass talking to their clients. They'll get maybe a 10% discount or something like that. But that's kind of your range that you're looking at. That's a good bit less than what we're seeing anybody else in the market do. And I don't know anyone that's doing it all the way. Specifically, the whole QTL analysis and looking, in detail at what's required on the network. I mean, if you're not a claim analytics platform, it's just real hard to do this kind of stuff. So we're taking advantage of that a little bit. All right. So yes, that price that price is all in. That's everything, because it's kind of a misnomer to call it. I know you're like, well, wait a minute. You just talked about a lot of stuff, but the name of this thing is NQTL analysis service. Yeah, everyone talks about it. That's what everyone's calling it. It's really comparative analysis, MEPA compliance, but the NQTL stuff this is the real hard stuff. And so that includes everything. So everything that a client's going to need in terms of overall compliance out of the self-compliance tool, that includes everything. How easy is the timeline for completion? That is a great question. All right, so God forbid none of us end up in this situation, but this is a little bit like being in a theater with someone yells fire. Everyone's running through the same door at the same time. We kind of have a strategy to where we're doing it. It's almost like we're banking on good faith effort, in that we bring on a client and we send a discovery. For people that are familiar working with us on the ACA side, ACA reporting side, similar in that we're doing a limited discovery kind of intake from you, and then we're doing an overall discovery session to find out, all right, who are the vendors, who are the broker, what TPAs, how many networks, who are the players, who do we have to contact, and we expect that to take a couple of weeks, from the time we start. When we have a signed contract, we get a signed business associate agreement. We need both. And assuming that that just runs forward, as soon as the first invoice is paid, you get in line. And should be in maybe a couple of weeks, we should be able to be done with that first section. Then we have to send out the request to the folks. And then it's really just about following up, finding out where the information is, asking, and gathering the information that we need from the vendors, getting the claims, so it's going to take some time. But we kind of have an implementation schedule to where, you're looking at, 3 or 4 months to kind of, and hopefully you're getting it done by that time. Even if you're at 6 months, I don't think it's the end of the world. But what kind of we're doing is kind of those warning signs. We're going there first. All right, so if I get back to like provider reimbursement warning, we're going with all these things that are like, hey, this is a major problem. Well, if I can get there. All of these down here at the end that are warning signs. There's lots of warning signs. We're starting there, and there's some other guidance about warning signs. We want to get that done first. If they're a plan document, we do not rewrite your plan document for $39.99. That's not happening. We are reviewing it in regard to this stuff, but hopefully that kind of went a little bit everywhere, but that's a little bit on the timeline. Where do you go for an official quote? You can go to NQTL analysis.com, NQTLanalysis.com. You'll see if you end up searching on the internet, we own, I wouldn't say everything, but we own just about everything, like NQTLcompliance.com. You'll see, lots of stuff out there. But NQTLanalysis.com. You can contact us, and we can, if you want to move forward, we'll get you that quote and can move it forward. All right, so boy, I got the coming in now. Let's see here. I believe the likelihood will increase once the mental health providers get wind of this and understand the requirements. Absolutely. There's these, I don't know if it's the Kennedy Foundation or something. There are organizations that they're nonprofits that what they're doing is getting the word out. There are people putting significant amounts of money and research into getting the word out on this whole thing. What is the frequency of reporting? Well, the reporting we're going to find out about in a year. What they're saying right now is that essentially it's a living, breathing document. So what does that mean? It means ongoing. Is kind of the way that we're interpreting it. Let's see here. Let's see if I can search for robust. Plan sponsors must perform a detailed and ongoing. It has to be up to date. So in other words, you just think about your provider reimbursements and what have you. They're going to look at that math, and you have to have the details. Like, well, how'd you come up with that math? And you go, well, I did it 2 years ago. Like, that's not what you're supposed to be doing. You're supposed to be looking at this stuff ongoing. Not to mention a lot of this, like for instance, the auditing from the TPA of, okay, well, what did you deny last year in terms of mental health, substance abuse disorder claims versus medical and surgical? The same thing in terms of these PBMs. Now, the PBMs have been very much like, oh, yeah, I mean, this just doesn't really apply to us. Well, they can say that all they want to. Like, the reality of it is that, and they're probably fine, but there's a lot of questions that have to be answered, because as you start digging in this, y'all, there's just a lot of medical management that ends up happening. Yes, there's questions about dedicated account manager. That's a great, this is actually from a broker. That's a really good question. I would think they're asking, would I have to work with multiple account managers on multiple accounts? I don't think so. We're looking at this thing as like, this any way you like, any way you look at it, it's kind of like ACA reporting. It's a heavy lift for the first couple of years. And so, yes, dedicated account managers, very similar to this person's worked with us for years on ACA reporting, very similar to that. I'm not 100% sure, but I would certainly imagine that we could probably come up with a way to keep you with one account manager. It certainly makes sense to me. Do we have an attorney reviewing the plan language piece? We can, but that's going to be a lot more expensive. We're looking at a very narrow focus of NQTLs, and quite frankly, in terms of this stuff, we're going to know more than they do. If you want a full review, though, we do have some attorneys that we have relationships with. It'll be less expensive, but just having an attorney to review the plan language is going to be pretty expensive. But some people might need that, and which is like if we find an issue, we're not rewriting it, but we can look and go, hang on one second, like this is what we're doing all day, every day. We're asking this TPA, well, how are you doing this? What is in the claim systems in terms of exclusions and the way that how are you defining, how are you even defining what mental health and substance use disorders are? Are you using DSM? Like those type of very specific things in terms of implementation, an attorney's not even going to know that stuff. For a plan that has multiple plans, yes, great question. A plan has to look at every plan separately. Every way that these QTLs and NQTLs and plan limits can be applied on a group basis, all of them have to be looked at and analyzed separately. We will be doing, like, our standard price is going to include your normal, like that $39.99 that we're charging a year. It's subject to probably be a little cheaper than that on renewal in the future. But as soon as we know a little bit more about what the reporting requirements are, we have to look at every plan separately. We're assuming you have one TPA, one PBM, that's even a separate one network, and up to 3 different plans. If you have more than that, it's going to be a bump. If you have 6 plans, we have to look at all 6. And so it's probably going to be $250 more per plan. But I think in this case, a person just has like 2 plans or 3 plans, so you'll be fine. Very nice comments. Thank you very much. PBM concerns. There's a number of things about refusal to pay for higher dollar medications. It's a great one, right? So refusal to pay for high dollar fail first, right? So that's what they refer to it as. Fail first policies. Step there. Nope, not okay. There's a great resource for you guys. If you guys go to NQTL analysis, you can go to FAQ. All right, there's a bunch of them. Can I do this myself? Not many will opt for it. What will the DOL not accept? This is really, who enforces MIPA? What are the financial penalties? This is a great FAQ that will continue to improve. It should be a really good resource for you. But yeah, it's the PBM is all that stuff. And again, none of this necessarily means you have a problem. It just means you got to do the due diligence and make sure that you don't have a problem. Are y'all tired of hearing me talk? Because I'm exhausted. So I think I actually made it through the questions. Here's our telephone number. You can email us and let us know. I hope this was helpful. Thank you, guys. It's really some great feedback. This is a bear to get your arms around. I think it's like anything, though. It actually is it's certainly a business opportunity. Regardless, we might as well embrace it, y'all, because this thing is not going away. And hopefully this can be helpful to get you guys a little bit ahead of your competitors. All right. Well, have a great rest of the day. And I will try to remember, if somebody can remember to ping me, I'll try to remember to actually load this and to send you guys the recording as well. And I hope you guys have a great day. Thanks so much. See you.